Okay, so some of the variations in the anatomy and physiology in the upper airway of a child versus an adult. So the nose, the throat, and the trachea are all slightly different. In the nose, infants are obligate nose breathers, which means they are obligated to breathe through their nose. You rarely will ever see an infant breathing with their mouth open. It is not a normal thing for their little brains to do that. They produce very little mucus, so they don't have a lot in there to trap the bugs, the viruses, the bacteria, and the yucks. So this does make them more susceptible to infection within the airway. Let's see. They have much smaller nasal passages. All it takes is to look at the nostrils of a baby or a small child versus your own, and you can see that the passages are just so much smaller, so it really doesn't take much swelling or edema, much mucus to block them off. And their sinuses are not fully developed. So they can develop more obstructions. They can't breathe and eat at the same time if their nose is obstructed. And because their sinuses aren't developed in the frontal region, these are most often associated with sinus infections, and they don't fully develop until you're around 6 to 8 years old. You're not going to see a lot of actual sinus infections in an infant to a toddler. We're going to see sinus infections develop more in the school-age child. So the throat area of an infant and a child as related to an adult. So the tongue of an infant is larger in an infant than in an adult in relation to the oropharynx cavity. So swelling and displacement of the tongue can quickly lead to severe airway obstruction. Children are going to have also enlarged tonsillar and adenoid tissue, and this can lead to airway obstruction as well. So some of the changes you might see in the trachea are that the actual lumen of the airway of the trachea is quite a bit smaller in infants and children than it is in the adults. On the next slide, we'll look at a visual representation of that. So any resistance that we have to air going through that lumen, such as edema or mucus production, is going to be significant more for a child or an infant than it would in an adult. So the larynx itself is narrowed in a child. So any child under the age of 10, the actual cricoid cartilage, it's underdeveloped. So they have laryngeal narrowing. The larynx is more funnel shaped as opposed to a cylinder that you would find in adulthood. This does predispose children to risks for obstruction, again, by mucus, swelling, also foreign bodies. Neonates have a 50% smaller laryngeal funnel than an adult. 50%. Whew. So a child's airway, highly compliant, means it is able to move more, stretch more. Let's look at this picture. So as you can see, if you look at the picture in column A, that's a patent airway of a child, and underneath it is a patent airway of an adult. And then picture B, or column B, shows just 1 millimeter of swelling. So as you can see, from picture A to B, 1 millimeter of swelling makes a marked amount of difference in the patency and the lumen, the diameter of it, as opposed to an adult. An adult can have a millimeter of swelling and still have quite a bit of space for air to pass through. Imagine also that they're frequently going to have mucus building up in these areas. All right, bifurcation of the trachea. So a bifurcation is where something branches into two. This occurs at the level of the third thoracic vertebrae in children. It's much lower in adults. This is important when you're suctioning or intubating a child. The measurement at which you are going to insert the tip of the suction catheter to be able to hit the right above that point where they start to gag and cough is going to be much higher up in their chest than it would be in an adult. In an infant and child, the bronchi and bronchioles are narrower in diameter, so this increases their risk for lower airway obstruction because they can get something stuck higher up than we would if we breathed it into our airway. So a lower airway obstruction that happens during exhalation, it often results from bronchiolitis or asthma, or is caused by a foreign body into the airway. So little ones, they have smaller numbers of alveoli. This puts them at a higher risk of hypoxemia because they have less alveoli. So at 24 weeks gestation, the alveoli start to develop. And this is why premature infants often need respiratory support after they have been born, and they receive artificial surfactant. If you guys don't know what surfactant is, look it up. A term infant, an infant born at full gestation, will have approximately 50 million alveoli. But by the time they are 7 to 8 years old, they will have their adult number of 300 million alveoli. So let's compare and contrast. A child can have 300 million, whereas an infant, a healthy infant, only has 50 million. So if you can imagine a premature infant, they're going to have markedly less than that, and it's really going to put them at risk if they do develop edema, mucosal involvement, or respiratory issues. It's going to put them at risk because they don't have as many sacs transferring that oxygen to where their body needs it. So the chest wall of an infant is highly pliable. So you might see the term FRC, or functional residual capacity, in your book. It's the volume of air that's present in the lungs at the end of passive expiration, which means you're just breathing out. You're not forcing more breath out than you normally would. It's a passive exhale. So an infant's chest wall, their FRC is reduced if their respiratory effort is diminished. This is a strange concept. So their tidal volume, their overall tidal volume of their lungs, is very dependent on their diaphragm. So if there's impairment of movement, such as in like asthma, their respiration is going to be further compromised. I wouldn't focus a whole lot on that. I will just focus on the fact that the chest wall of an infant is highly pliable.